കേൾക്കാമോ? ഹലോ ഹലോ എന്നതാണ് കേൾക്കാമോ?
ഇതിനകത്ത് സാറിന്റെ ലിങ്ക് ഓപ്പൺ ആക്കാം. സാറിന് ലിങ്ക് വന്നതാണ്. സാറിന്റെ മെയിലിൽ ലിങ്ക് ഉണ്ട്. പാനലിസ്റ്റ് സിസ്റ്റർ കണ്ടുപിടിച്ചിട്ട് ആദ്യം ഞാനൊരു ഇൻട്രൊഡക്ഷൻ പറയും. ഇതിപ്പം
ഹലോ അതെ അതെ അതെ, ഞാൻ അഡ്മിറ്റ് ചെയ്യാനുള്ള പ്രശ്നമില്ല. ഇപ്പത്തേക്ക് ഞാൻ ചെയ്യാം, കുഴപ്പമില്ല. ആ സമയത്ത് ആരാ പേര് പറഞ്ഞോ? സന്തോഷ്. ഓക്കെ 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 ഓക്കെ. ശരി. ഉണ്ട്. കോ ഹോസ്റ്റ് ആക്ച്വലി പാനലിസ്റ്റ് ആണ്. മറ്റേ ഡെന്റൽ കോളേജിലെ പ്രിൻസിപ്പളും പാനലിസ്റ്റ് ആണ്. അദ്ദേഹത്തിന്റെ അതെ 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 അതെ, എല്ലാവരും അവരവരുടെ ആ മെയിൽ വന്നിട്ടുണ്ട്. എന്തോ അതെ 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 അതെ. ഹലോ ഇതെടുക്ക് വെക്ക്. Sister, hello. Vinitha ma'am. Hello, Vinitha ma'am. Hello, Vinitha ma'am. ഹലോ, സ്റ്റാർട്ട് ചെയ്യാം. പക്ഷേ കുട്ടികൾ ആരും കയറിയിട്ടില്ല. അല്ല അല്ല,
Hello. Hello, Vinitha ma'am. Hello.
ഡോക്ടർ വീണ കേൾക്കാമല്ലോ അല്ലേ? ഹലോ ഡോക്ടർ വീണ?
കേക്കാം കേട്ടോ, കേക്കാം.
കേൾക്കാം.
ഞാൻ വീഡിയോ ഒന്ന് ഓഫാക്കി വെച്ചതാണേ. ഞാൻ
ഇല്ല
മാസ്ക് കെട്ടിയിരിക്കും.
കുഴപ്പമില്ല.
എന്റെ സ്പീച്ച്
കേൾക്കാമോ? ഹലോ, വെറ്റുമടത്തിന് കേൾക്കുമല്ലേ?
ഹലോ, കേക്കാവോ? വിനീത മാഡം കേക്കാവോ?
കേൾക്കാൻ പറ്റുന്നുണ്ട്.
വെറ്റുമടത്തിന് കേൾക്കാവോ?
ലൈവാണേ.
ലേറ്റ് ആവുന്നതിനനുസരിച്ച് സമയം മുന്നോട്ട് കിട്ടുമോ?
നമുക്ക് നോക്കാം. ഇപ്പം
ഗുഡ് മോർണിംഗ് സിസ്റ്റർ ജി. കേട്ടില്ലേ? ഗുഡ് മോർണിംഗ് സിസ്റ്റർ ജി, ഗുഡ് മോർണിംഗ്.
A warm good morning to one and all. I am Mrs. Vinitha Jacob, HOD Department of Mental Health Nursing, Pushpagiri College of Nursing. World Alzheimer's Month is an international campaign by Alzheimer's Disease International every September to raise awareness and challenge the stigma that surrounds dementia. World Alzheimer's Month was launched in 2012 and observe World Alzheimer's Day on 21st September each year. September 2020 will mark the 9th World Alzheimer's Month campaign. The theme for this year campaign built on the theme from 2019, let's talk about dementia. The impact of World Alzheimer's Month is growing, but the stigmatization and misinformation that surrounds dementia remains a global problem that requires global action. In May 2017, WHO adopted the Global Plan of Action on the Public Health Response to Dementia 2017-2025. Global awareness campaigns such as World Alzheimer's Month directly contribute towards the global plan with the eventual target of having all 194 member states having at least one functioning national public awareness campaign on dementia to foster a dementia-inclusive society by 2025. ADI relies on the involvement of a large network of members, healthcare professionals, people living with dementia, care partners, policymakers, and other stakeholders worldwide to support World Alzheimer's Month. Individuals, groups, and organizations can help us raise awareness about dementia through their networks and communication platforms with the stakeholders and local communities, and by using their local, regional, national, and international outreach. Keeping this in mind, we dedicate this webinar to all those who suffer from Alzheimer's disease and their caretakers, and invite all your cooperation towards public awareness campaign. So before starting the session, we shall pray silently to the Almighty for the blessings. Now, I would like to request Sister Deepa Oasis, lecturer, Department of Mental Health Nursing, to deliver welcome address.
Thank you, ma'am. A warm good morning to all. If you have knowledge, let others light their candles in it, said by Margaret Fuller, a famous American journalist. The capacity to learn is a gift. The ability to learn is a skill. The willingness to learn is a choice. Respected dignitaries, principals, speakers, doctors, teachers, delegates, and dear students. We are living in a dynamic world. Competency and excellence are the most important part of today's scenario. The world of healthcare is challenging. In order to meet the new challenges in this world, with fast growing medical and technological advancements, it is essential that we have to equip ourselves with adequate knowledge. A well-trained personnel in the nursing profession or healthcare profession who can easily combine compassion with skill is a great asset for any healthcare institution and to the society. Intellectual as well as human qualities are required in abundance to become a good nurse. Knowledge is love, light, and vision. Hope this webinar will help us to improve professional practice, clinical competence, and enlighten our hearts and minds to make our profession a noble one. On this occasion, it's my privilege and great joy to welcome you all for this gathering. With immense pleasure, I welcome Dr. Santosh M. Matthews, Principal, Pushpagiri College of Pharmacy, who has gladly consented to inaugurate this webinar. Welcome you, sir. If your actions inspire others to dream more, learn more, and do more, you are a leader. I'm glad to extend a warm welcome to Sister Therese Saisi, Principal, Pushpagiri College of Nursing, to this webinar. She is a constant source of motivation and guidance to all of us, which helps us to work with zeal and dedication. Attitude and personality are as important as experience and ability. Today we have with us three eminent speakers, Dr. Roy Abraham Kallivayalil, HOD Professor and Department of Psychiatry, Pushpagiri Institute of Medical Science and Tiruvalla, Dr. Betty P. Kunyumon, Assistant Professor, Government College of Nursing, Kottayam, and Dr. Reena George, Assistant Professor, HOD Mental Health Nursing, Institute of Mental Health and Neurosciences, Kozhikode. We are fortunate to have you here with us today. And warm welcome to you, respected Dr. Roy, Dr. Betty, and Dr. Reena. Knowledge is of no values unless you put it into practice. I wholeheartedly welcome our HODs, teaching and non-teaching faculty to this webinar. Next, I welcome Professor Vinitha Jacob, HOD Mental Health Nursing, Pushpagiri College of Nursing, who worked hard to organize this webinar. A special welcome to all our delegates. We have around 800 delegates from all over India. Other than Kerala, we have delegates from Karnataka, Tamil Nadu, Telangana, Andhra Pradesh, Uttar Pradesh, Maharashtra, Odisha, Meghalaya, Manipur, Sikkim, Bihar, Haryana, Goa, Rajasthan, and Jammu Kashmir. And also from other countries like Saudi Arabia, Dubai, Qatar, Kuwait, UK, Ireland, and Australia. Sorry if I have missed anyone. Your good responses was really an inspiration for us to conduct this webinar. Hearty welcome to all our delegates. Finally, I'm so glad to welcome our dear students from our own institution and other institutions as well. Once again, a warm welcome to you and have a fruitful day. Wish all teachers a happy Teachers' Day. Thank you.
Thank you, sister, for the welcome address, and we welcome you too. I consider it a great honor to invite our distinguished guest, Dr. Santosh M. Matthews, Principal, Pushpagiri College of Pharmacy, Tiruvalla, to inaugurate the webinar.
Thank you, Professor Vinny. Good morning to all. Respected Sister Therese, Principal of Pushpagiri College of Nursing, all the organizers, eminent speakers, Dr. Roy, Dr. Betty, and Dr. Reena, and all the participants from various parts of India and abroad attending this webinar. Greetings to all, and also Happy Teachers' Day. Seminars and conferences are inevitable for any profession to enhance knowledge and awareness, especially in the practice of profession in the field of medical science. But unfortunately, due to COVID-19, all these type of programs and get-together and gatherings are suspended temporarily. But we are fortunate that our electronic system is developed to such an extent that we are able to listen, to share the views, knowledge, the concepts of experienced persons through webinar. We are all gathered today here for such a wonderful webinar on current trends in the management of patients with Alzheimer's disease. At the outset, I congratulate College of Nursing team for arranging such a webinar on such a relevant topic. Congratulations to the principal, Professor Sister Therese, the organizers, Professor Vinita Jacob, Sister Deepa, and their team. If I forget my key somewhere, and if I am able to find it out after recollecting my memories, it is forgetfulness. But if I am not able to relocate it after doing a long time thought process, this may be the beginning of Alzheimer's. To talk on this, we have very eminent persons in this area of specialization. Dr. Roy Abraham is head of the psychiatry department of Pushpagiri Medical College and Hospital. He is a renowned person in national and at international levels. And Dr. Betty and Dr. Reena, both are basically from nursing profession. So definitely they will be able to correlate the treatment of Alzheimer's in the patient care. With these words, I am extremely happy with the permission of the organizing committee, all the speakers, and all those who attend this seminar to declare this webinar on current trends in management of patients with Alzheimer's disease declared inaugurated. Thank you and all the best.
It's my privilege to invite our dear principal, the support and strength of our college, for the felicitation. Sister, please.
Dear respected Santosh sir, most loving Roy sir, Dear respected Santosh sir, most loving Roy sir, other resource persons, faculty members, dear delegates and students. I am very much impressed to address in this webinar about current trends in management of patients with Alzheimer's disease. The topic as such, it is very relevant because we know that it is a neurodegenerative disease that usually starts slowly and gradually worsens over time. Moreover, the importance of this webinar is we have some chunks of two institutions. A well-known pharmacologist is inaugurating this webinar. That is our Dr. Santosh Matthew, Principal of Pushpagiri Pharmacy College. Another popular personality, Dr. Roy Kallivayalil, a world-known psychiatrist, is leading one of the sessions. From his profile, you will understand the popularity of Dr. Roy sir. Both dear doctors are the chunks of Pushpagiri. Along with that, we have two well-known Mullerians, Dr. Betty P. Kunyumon and Dr. Reena George. I am happy to say that we all studied in Father Muller's around nearby years. Again, I can say that they are the chunks of our alumni of Father Muller College of Nursing. Also, very happily, I can say Professor Vinita and Sister Deepa, the organizers of this program, also are the alumni of Father Muller College of Nursing. We all are proud to be Pushpagirians and Mullerians. I wish all the prayers and best wishes to the resource persons, organizers, and to the delegates of this webinar. Have a fruitful day. Thank you.
Thank you very much, sister, for your inspiring message. Now we shall start with our session. I am profusely elated to introduce our speaker for the first session of the day, a very knowledgeable, creative, and enthusiastic personality, Dr. Betty P. Kunyumon, Assistant Professor, Government College of Nursing, Medical College, Kottayam. Madam has completed MSc Nursing from Father Muller College of Nursing, Mangalore in 2003 and PhD from Kerala University. Worked in Amata, Kozhikode Government College of Nursing and Alappuzha Government College of Nursing. Madam is very active in the COVID management activities and has prepared 4 YouTube videos on COVID-19 management recently. Madam was resource person for many government funded and other workshops, and to name a few of them are workshop on medical emergencies, workshop on infection control and patient safety, food and lifestyle to ensure health during pandemic, a conference of directors and project personnel of Diocese of Kerala Social Service Forum, workshop on patient safety and legal concerns, workshop on respiratory emergencies, workshop on management for effective managers, and such as. Madam has organized many workshops, and to name a few of them: workshop on medical emergencies, workshop on management for effective managers, workshop on research methodology, and central government sponsored training workshops for staff nurses on critical care nursing, and many other funded training programs. Madam has participated in many national and international workshops and training programs too. A very warm welcome, Madam.
Ma'am, you have to unmute. Can't hear.
And
A warm good morning to one and all. First of all, let me thank Principal and Professor Vinita Madam for inviting me for this session. Hope my screen is visible.
yes, yes. Yes, it's visible.
So we all know that it's Alzheimer's disease. Already, Sister and Professor Vinita Madam has given a brief introduction about this disease. We all know that it's a chronic, progressive, neurodegenerative disease of brain, and it is a form of dementia. But we know that it is this dementia. This Alzheimer's disease. All the Alzheimer's disease are dementia, but all the dementias are not Alzheimer's disease. So it is a progressive decline in two or more areas of the cognition. That is mainly memory will be affected. Initially, the memory will be affected, and sometimes the other areas also will be affected. For example, language, calculation, personality change, etc. will be affected. So, in nutshell, we can say that it is a irreversible progressive neurodegenerative impairment. So we all know that all the chronic diseases, like COPD, chronic renal disease, chronic liver disease, all these diseases are not developing overall, uh, not all on a sudden. It is developed progressively, and decades after many decades only the symptoms will appear. So similarly, this Alzheimer's disease also is a chronic progressive disease which will affect the memory and other cognitive functions of the individual. Now let me see the history of Alzheimer's disease. I hope you may be knowing that is Dr. Aloysius Alzheimer's. He is the one who has found out this disease. That is, he had a patient. Her name was Auguste Dieter. This Auguste Dieter had unusual mental symptoms she had shown. So what this Alzheimer did, he was a German psychiatrist and neuropathologist. He was following this patient, and later, after the death of the patient, he could find out that there are some abnormal clumps and tangled bundles of fibers on the neurons in the autopsy of that patient. And there was loss of connection between the neurons in the brain, and like that he identified the condition as pre-senile dementia. And after that, at the age of 51, this Alzheimer died due to heart failure. But one of the famous psychiatrists, that is Emil Kreplan, he was a friend of this Alzheimer. So both of them were working on this patient. So after the death of Alzheimer, uh, this work was continued by Emil Kreplan, and he renamed the disease, this presenile dementia, he renamed it as Alzheimer's disease. So that is the history of this name behind this disease. Then when we look into the epidemiology, it is estimated that by 2050, now it is 2020, by 2050, there will be 106 million people living with Alzheimer's disease. After 30 years, that means in this younger generation will be, the younger generation of at present will be aged population of that time. So at that time, after 30 years, there will be 106 million of Alzheimer's disease patients. And the incidence reported by the WHO shows that over 65 years, there's 8 percentage of the people will be having Alzheimer's disease. Over the age of 75 years, 15 to 20 percentage of the people will be having Alzheimer's disease. And over 85 years, 20 to 50 percentage of the people will be having Alzheimer's disease. And it is a fact that up to 60 years, these patients will be symptom free. Though the chronic changes are taking place inside the brain, they will be symptom free up to 60 years. In Indian statistics shows that 3 million Alzheimer's disease patients are there in India. That is 4%. A study done by Madhuranath et al. Of Sritra Institute of Medical Science, they have reported that above 55 years, 11.67% will be there. If we are taking a 1,000 persons above 55 years, there will be 11.67 patients will be there. US report shows that there are 4 lakh deaths in US per year due to Alzheimer's disease. And in that 2 lakh Alzheimer's disease patients are under the age of 65. That means it is a early onset Alzheimer's or younger onset Alzheimer's disease. And they also, US reports also states that this Alzheimer's disease is the 6th leading cause of death in US. Now, I'm going to explain about the etiology. Uh, when we look into the etiology, there are 2 types of Alzheimer's disease. That is early onset Alzheimer's disease and late onset Alzheimer's disease. Early onset means it is before 60 years. Usually it will be of mild form, and there will be impairment in the memory. Sometimes there will be difficulty in the performance of task, or the difficulty in concentration, difficulty in word finding, orientation, etc. And in most of the cases, the cause will be familial Alzheimer's disease. That is the autosomal dominant inheritance. It occurs before 65 years. Most common 3 reasons are mutations in the gene. That is mutations in the amyloid precursor protein. amyloid protein is the main thing which can result in pathological changes in the brain in Alzheimer's disease patients. So amyloid precursor protein, presenilin 1, presenilin 2. These are the three genes which encode these proteins. So mutation in this gene, that is one common finding. Then another finding is apolipoprotein E, presence of apolipoprotein E G. Then another etiology is this Alzheimer's disease is seen in patients with Down syndrome. So these are the usual presentation in early onset Alzheimer's disease. Next is the late onset. Most of the cases are this late onset Alzheimer's disease. Only less than 5% are early onset Alzheimer's disease. In the late onset Alzheimer's disease, it is also called sporadic Alzheimer's disease. And here the risk factors are lifestyle changes, environmental factors, and genetic differences. So risk factors altogether, we can say family history, age, lifestyle factors are there, low education level, then other factors like hypertension, dyslipidemia, diabetes, obesity, smoking, then head injury, environmental toxins, gender, all these are different risk factors of Alzheimer's disease. When we look into the details of these risk factors, we all know that there will be degenerative changes due to the aging, which include atrophy, mitochondrial dysfunction, production of unstable molecules like free radicals, then inflammatory changes, vascular changes. All these will contribute to age-related changes, and the incidence will be more as the age advances. Next is another fact is that it is more common in females. So the reasons are given, that is females lives more than men. That may be one reason. Another reason they have said that is because of the decreased level of education or decreased level of socialization, there are more chance of development of Alzheimer's disease in females. And next is the socialization. That is another risk factor. That is people living lonely, and if there is low socialization, they will be at high risk for Alzheimer's disease. We all know that we are living in the era of Corona. That is, we are maintaining social distancing, and we are following all the isolation practices. So there is more chance for development of this type of diseases. Those who are having decreased social stimulation. Another risk factor is educational status. That is, those who are having low education, it is associated with greater risk of this disease. So education raises the level of intellectual reserve. So we may say that the ideal mind is a devil's workshop. Like that, if the brain is continuously active, it will decrease the risk of Alzheimer's disease. And research reports also shows that the more we are getting educated, less there is chance of development of Alzheimer's disease. Then the environmental factors also have many influences. That is exposure to certain metals like aluminum, copper, pesticides, flame retardants. Flame retardants means agents used to stop the flame. Then air pollutants. All these can result in changes in the neurons. That is inflammation in the neurons. Then pathological changes in the neurons. It will alter the pathway. It will alter the metabolism of the neurons. So then some other risk factors, mild cognitive impairment. This mild cognitive impairment is the initial stage or a preclinical stage of Alzheimer's disease. So those who are having mild cognitive impairment, it can occur due to other diseases also. So this mild cognitive impairment is a risk factor. Those who have this impairment, there is more chance of development of Alzheimer's disease. Then lack of sleep, lack of exercise, obesity. Then already I have told chronic diseases like diabetes, hypertension, CVA, CAD, and all. Then habits like smoking, dietary factors, vitamin D deficiency. Then lack of mental stimulation, lack of social engagement. All these can contribute to development of Alzheimer's disease. Next, we will move on to the pathophysiology. This pathophysiology of Alzheimer's disease, actually, it is even now it is not very clear about the pathophysiological changes. There are many hypotheses. That is cholinergic hypothesis, Tau hypothesis, and amyloid hypothesis. Let us see one by one. In the cholinergic hypothesis, they have mentioned that this Alzheimer's disease is caused by the reduction in the acetylcholine. We all know that this acetylcholine is a chief neurotransmitter which is mainly important for the peripheral nervous system. So reduction in the acetylcholine can result in Alzheimer's disease. Next is the tau hypothesis. Tau protein. So that is a protein which has a major role in stabilizing the microtubules of the neurons. It has a major role in stabilizing the microtubules. So that is the normal function. Thus, it will help in the axonal transport, and thus this tau protein will help in the neurite outgrowth, and it will help in the synaptic plasticity. That is the normal case of normal function of the tau protein. But in case of Alzheimer's disease, what will happen in the this disease? This tau protein will come away from the. It will go away from the microtubules, and it will stick each other. And this detached tau protein will pair with each other, and it will form neurofibrillary tangles. I hope you know the meaning of tangles. So it will together it will form tangles, fibrillary tangles inside the nerve cells, and damaging the microtubules, and it will disrupt the cell's cytoskeleton, and it will disrupt the neurons transport system, and thus it will disrupt the cell's ability to communicate with other cells. In the later stage, ultimately it will result in the cell death, that is the cell death of the neurons. That is one hypothesis. Another important hypothesis is the amyloid hypothesis. That is, it is the integral. This amyloid protein, that is also normally it is an integral part of the membrane protein, and it is concentrated in the synapses. That is in the normal case. It is a regulator of the synapses formation, and it helps in the neural plasticity, and it is essential for the neural growth and repair. That is the normal case. But in case of Alzheimer's disease, what happens is there will be abnormal level of amyloid beta amyloid protein, and it will chemically stick each other. It will clump together and form a plaque. We all know that there are different types of plaque. We have this atherosclerotic plaque, dental plaque, like that. Here in the neurons, this amyloid protein will clump together, and it will form plaque, and it will become toxic, and it will disrupt the function of the brain cells and result in a series of toxic events, and thus the neuron will get damaged, and there will be loss of connection, and eventually there is death of the nerve cells. So ultimately, because of all these cholinergic tau and amyloid protein effects, there will be um, hazardous effect to the neurons. That is faulty cell cycle, neuronal toxicity. There will be regional neuronal and synaptic loss will be there. Synaptic loss and cell death occurs, and it will if there is decrease in the acetylcholine, that will affect the memory and learning. The damage starts in the brain. Especially the area affected is initially the area affected is hippocampus and entorhinal cortex. These areas are situated just above the corpus callosum, and it is the medial. It is actually located in the deepest part of the temporal lobe and just over the corpus callosum, and it has a major role in the memory and other cognitive function. So initially, this part of the brain will be affected. Later, the additional parts will be affected, and later, in the severe case, widespread shrinking of the brain cells and widespread atrophy will occur. So in that time, the changes will be there. That is irreversible changes which cannot be reverted back, and it will be progressive, and that will lead to severe form of Alzheimer's disease. Next, let me see the difference between the dementia and Alzheimer's disease. That is, dementia is a broader term, and there will be memory loss, there will be confusion, and the causes may be many. There may be medical causes, neurological causes, or psychological causes. But Alzheimer's disease, it is a one type of dementia, and it has got specific causes, and it is seen in aged, and there is family history. There is genetics is another factor, and the symptoms worsen over the time. So all the Alzheimer's disease are dementia, but all the dementia are not Alzheimer's disease. So we all know that Alzheimer's disease, the features of Alzheimer's disease, that there will be memory loss, there will be changes in the mood, personality changes, behavioral changes. The person will misplace the belongings. It is hard to complete a familiar task. They will be confused. They may get lost in a familiar place. If we send them for a, we send them to a shop, they will lose the in between. They may not come back to the home. Then social withdrawal, then poor judgment, then struggling to communicate. There will be changes in the visual spatial skills. Like that, so many features are there. But these features, that is, some skills are preserved. these skills will not be lost. That is preserved skills. So, that means this person will be able to read a book. The person will be able to listen music. The person will be able to sing. The person will be able to draw a picture, and the person will be able to do crafts work and all. Because these parts will become these parts of the brain will be affected in the later stage only. Initially, it will not be affected. So these skills will be retained till the end. So these are some preserved skills. Next, I am going to explain about the clinical features based on the stages. There are three stages in the Alzheimer's disease. That is stage 1, that is called early stage or mild form of Alzheimer's disease. Then stage 2 is there, that is called middle stage, or it is a moderate form of Alzheimer's disease. Then stage 3, it is a severe form of Alzheimer's disease or late stage. So like that, three stages are there. First one is the stage 1. The duration is 1 to 3 years, and the memory will be lost. That is, the new learning will be defective. That is the most important thing. The recent memories will be affected. Remote memory will not be that much affected. Then visuospatial skills will be affected. Visuospatial skills will be affected. That means the patient, sometimes the patient will not be able to drive a vehicle because the patient does not, the patient will not be able to analyze and perceive and analyze and interpret the distance between the vehicle or distance between the vehicle and a person. So like that, visuospatial skills will be impaired. Topographic disorientation will be there. Poor complex construction will be there. That is, there will be poor judgment, poor decision making. All those things will be there. Then in the language aspects, there will be poor word list generation, poor word finding. The person will find it difficult to tell the name of a thing. Then patient will be having difficulty in concentration. Patient will be having anomia. Anomia means patient fail to name the objects. Then speech problems will be there. Sometimes fluent aphasia will be there. Sometimes the patient may repeat the sentences. Patient may forget conversation. Patient may forget appointments. Patient may forget to pay bills. Then patient may be disoriented to time, place, and person. There will be difficulty in multitasking. There will be difficulty in managing money. Then other aspects also will be affected, like personal hygiene may be impaired. Then patient may misplace his possessions. Patient may get lost in familiar places. There will be lack of motivation. There will be lack of interest in the hobbies and activities. Then personality changes will be there. The patient may be irritable. The patient may behave indifferently. Psychiatric features like sadness, delusion, mild depression, etc. will be there. Motor functions will not be affected. That is all about stage 1. Next is stage 2 or moderate Alzheimer's disease or middle stage. So duration of this stage is 2 to 10 years. Here the memory, the recent, both the recent and remote recall will become impaired, and the patient may be unable to recall the names of people known to him. There will be visuospatial skills, that is already explained. Then language, there is fluent aphasia. That means the patient may say some words which we may not understand, but the patient has a meaning for that word to explain. So like the fluent aphasia will be there. There will be increased difficulty with speech. The patient may be having, the patient may not be able to do a calculation, simple mathematical task. Patient will be having praxis. That is, the patient will not be able to perform a intentional movement or a purposeful activity. For example, if we ask the patient to comb the hair, the patient will keep the comb there, and simply the person will circle the uh, comb, or he will keep the comb upside down like that. That is called ideomotor apraxia. Then personality changes will be there, that like indifference, irritability, etc. Then in stage 2, other features involve the patient need assistance in the activities of daily living. Patient will behave impulsively. That there will be behavioral abnormalities like sexual disinhibition, lack of concern, lack of apathy, and sometimes the patient may show alteration in the perception. There will be decreased disturbance in the appetite, disturbance in the sleep, the lack of insight, paranoia, delusions, hallucinations, etc. can occur, and the duration is 4 years. Next is the stage 3, that is the severe form or the late stage of Alzheimer's disease. Usually the duration is 8 to 12 years, and the intellectual function will be severely deteriorated. The person will not recognize the relatives, friends, or family members. The person will be having difficulty in understanding and interpreting the events. The person will be having a limb rigidity and flexion posture. Almost all the time, the person will be confined to bed or confined to wheelchair. That means a total body shutdown. Then there will be sphincter control problems, that the patient may be having bowel and bladder incontinence. Then the severe forms of behavioral symptoms, that is apathy, mood swings, distrust, anxiety, irritability, agitation. Then sundowning, that means by evening the symptoms will worsen. That is called sundowning. Then psychosis. Then depression will be there. Withdrawal will be there. The wandering. The patient may go out of the house and will go away from the house. Then will have difficulty in eating, may be unable to communicate. Then inappropriate behavior they may show in the public, that I have already told, that is social disinhibition. Then patient may survive in the stage for 6 years or longer, and after that the patient will develop some other complication because of all these behaviors and the memory changes and the cognitive function. And after that there is chance of death. Most common cause of death is pneumonia. So that is all about the stages of Alzheimer's disease. In this picture, we can see initially there will be mild cognitive impairment due to Alzheimer's disease. At that time, the hippocampus and the entorhinal cortex will be affected. In the case of mild form of Alzheimer's disease, it will spread to the lateral temporal lobe and parietal lobe. Later, in the moderate, it will spread to the frontal lobe. And in the severe form, it will spread widely in the brain. That is, uh, large volume of the brain cells will be affected and it will result in brain atrophy. So next is the diagnostic test. In the diagnostic investigations, we will be collecting history about the patient's symptoms and all, that overall health we will be assessing. And medication, some medications are there like anticholinergic, anti-epileptic, anti-Parkinson's and drugs. All these can aggravate the risk for Alzheimer's disease. Then dietary history, health issues, activities of daily living, behavioral changes, personality changes, all these must be collected. History must be collected about all these things. Mental status examination must be done. Then physical examination must be done because there will be changes in the reflexes, muscle strength. In severe forms, I already told there will be motor features. There will be whether there is any problem in the coordination, any changes in the balance, any problem with the vision or hearing. So the importance of early diagnosis, it will help us to be prepared to face the features of the disease. But actually, this early diagnosis we cannot stop the disease or we cannot reverse the disease condition, but we can be prepared to face the disease condition. This is about the Alzheimer's disease assessment scale. This is prepared by a Rosen WG. That was in 1984. This scale is modified in 2018. This scale will help in identifying the Alzheimer's disease. This you can refer that is Alzheimer's disease assessment scale. This can be used to collect history and mental status examination of a patient with Alzheimer's disease. The next is the diagnostic criteria. That is a diagnostic statistical manual 5 version. That criteria, it shows that Alzheimer's disease, there is two cognitive syndrome. That is major and mild forms. Major symptoms include objective cognitive decline, that is severe enough to interfere with the activities of daily living in the absence of other disorders. In the absence of other disorders means there is no other medical, neurological or psychiatric disorders. So in the mild cognitive syndrome, there is mild cognitive decline that will not deprive them to lead an independent life, but still there is memory loss is there. But there is no deprivation in meeting the normal activities of daily living. So that is the diagnostic criteria by the DSM. Then the other diagnostic tests include the CSF level of amyloid protein. We have already discussed the importance of amyloid protein. CSF level will be low in case of Alzheimer's disease patient. Then tau protein level, that also will be very low in case of Alzheimer's disease patient. CSF tau protein value and CSF amyloid protein value. Then another one is PET scan. Fluorodeoxyglucose PET scan is done in order to know the metabolism. That it will we can see the areas of poor metabolism because of the degenerative changes. It is most commonly seen in the posterior cingulate gyrus, the area which is very important for the memory and other cognitive functions. So there is posterior predominant hypometabolism in the posterior cingulate gyrus. Then other diagnostic tests include some specific diagnostic, that is amyloid PET which will measure the extent of amyloid deposition. Then tau PET scan, which will measure the neurofibrillary tangles. These are the some imaging. Then laboratory investigations to rule out the other causes of this dementia. That is in order to rule out other medical and neurological causes, that is metabolic disorders, drug related causes, etc., can be diagnosed by doing lab investigations like urinary analysis, CBC, ESR, electrolytes, blood urine addition, creatinine, vitamin B12 levels, etc. Then structural imaging, CT and MRI can be done in order to rule out other causes like any ischemic changes, any neoplasms, any past history of head injury like that, where we can diagnose. That is global brain atrophy. In a patient with Alzheimer's disease, we can see there will be global brain atrophy with a pronounced ventricular enlargement. This picture also you can see there is shrinking or the atrophy of the brain cells. In the temporal lobe, there may be hypertrophy. Then these are the few differential diagnoses of Alzheimer's disease. That is, sometimes it may be due to the aging. It may not be a disease. It may be some mild changes due to aging. Sometimes it may be due to some other neurodegenerative disorders, or it may be due to a brain neoplasm, or there may be a history of subdural hematoma, or in case of normal pressure hydrocephalus, the patient may show all these symptoms. Then another differential diagnosis is CVA, then Parkinson's disease, sleep disturbances, effect of certain drugs, infections, and other medical conditions. Next, we will see the complications of Alzheimer's disease. This is very, very important because the death due to Alzheimer's disease is mainly due to these complications. Actually, the Alzheimer's disease will not go into a fatal effect. The fatal effect is only because of the complications that can arise due to the problems with the cognition. So in Alzheimer's disease, the patient will be having high risk for aspiration because of the they will not be eating properly, they will not be feeding themselves properly, there will be unsafe swallowing that can result in aspiration. Then there will be inadequate intake, decreased food intake that can result in malnutrition, that can result in dehydration. Sometimes we may be remembering our patients in the medical wards, they may be coming with the complaints of not taking food, not taking fluids and all. So there is chance of malnutrition, there is chance of dehydration, and they will be immobile, they will be confined to bed. So there is chance of complications of immobility. Then there will be chance of fall because of the visuospatial problems. There will be chance of fall, and as a result, there will be chance of fractures. Then because of the immobility, there is chance of deep vein thrombosis. Then immobility complications like pressure sore. Then patient may develop all types of infections, that is pneumonia, then catheter-related infections, wound infections, then impact of poor communication. That is another very, very important problem. That is the patient may not report other medical symptoms or other problems, and that will result in delayed diagnosis of the disease condition, other disease condition, and that will result in lethal effect. So there will be poor communication is a very big problem in Alzheimer's disease. Then poor compliance with the treatment of other disease. That is another major problem. If they are having some other disease like coronary artery disease or diabetes or hypertension or whatever, it is any other serious diseases, they will not take the medications properly because of the effect of this Alzheimer's disease, because of the lack of memory, because of the lack of initiative. They will not comply with the treatment of other disease. That will result in development of complications of that disease, and that will result in death. Then financial and legal issues, that is another complication. That is they will not be able to manage money, and they will not be able to pay, they will not be they may forget to pay the bills, or they may give more money if they are dealing with some financial matters. Then there are other legal issues also because of this decreased memory or lack of memory and lack of cognitive function. Others may misuse them, in the case of living will and all. So such legal issues also are there. Then safety issues I have already told. If there is having problem with the visuospatial skills, if there is problem with the cognitive function, it will affect the safety of the individual. So these are the different complications. So the next topic is the management of Alzheimer's disease, that will be taken by Dr. Roy sir. I hope it is, so far I have discussed about the definitions, the epidemiology, etiological factors, and the pathophysiology, and the different stages of Alzheimer's disease. Then I have explained about the various diagnostic investigation. Then I have explained about the differential diagnosis and complications of Alzheimer's disease. I hope it is clear. Thank you.
Madam has explained a detailed picture of Alzheimer's disease within a short period of time. Madam has explained about the history, epidemiology, etiology, risk factors, pathophysiology, clinical features, stages, diagnostic measures, and complications. Thank you, Madam, for sharing your great knowledge with us. That was a really informative session. Our question answer session will be at the last. So I will go to the next session. I consider it a great honor to welcome Dr. Roy Abraham Kallivalan, Professor and Head, Department of Psychiatry, Pushpagiri Institute of Medical Sciences, Tiruvalla, to this session. Sir, you hardly need any introduction. You have made all of us proud of your distinguished work in numerous capacities. A few of them to mention: Sir is Secretary General of the World Psychiatric Association, Geneva, and immediate past President of World Association of Social Psychiatry, Honorary Chair and Professor, Magister and Honorum at the Milan School of Medicine, Italy, and President of the National Alliance for Mental Health, India. Sir was the President of Indian Psychiatric Society during 2012-13. Sir served as the principal of Ernakulam Medical College, Kochi, India, and professor and head of psychiatry at Thrissur and Kottayam Government Medical Colleges, chairman, Board of Examiners, member, Board of Studies, and member, Faculty of Medicine of the Cochin University of Science and Technology, and member of the Senate of Mahatma Gandhi University, India. Sir has nearly 100 publications in peer-reviewed scientific journals and has edited the book Suicide Prevention, a Handbook for Community Gatekeepers. Sir was awarded the Best Doctor Award by Government of Kerala in 2007 and the World Federation of Mental Health Award for Meritorious Services to the cause of mental health in 2017. Sir is an International Distinguished Fellow of American Psychiatric Association. Ladies and gentlemen, we rarely get this kind of opportunity to listen to the words of a great knowledgeable speaker. Over to you, sir.
Good morning, everyone. At the outset, let me express my gratitude to the College of Nursing, and all our friends, especially Vinita Jacob, for inviting me. Today, unfortunately, I have a series of conferences and video meetings. So, but at the same time, I have taken permission from a meeting to skip out. I'll be talking on the recent advances of in the treatment of Alzheimer's disease. And shall I go to my presentation now? I think if you can permit.
Yes, sir. Yes, sir. Yes, sir.
So
Yes, sir.
I will share the screen then.
Okay, sir.
Is it visible now? The screen is visible, I hope.
Yes.
You need to click on the share button.
Share button.
Are you able to see the screen now?
No, slides cannot be seen.
Slides cannot be seen. Okay, hope. I had, then I must see. Okay. I had to. Slides are not visible now. Share the screen.
Share screen, no.
Share, I'll put now. Okay.
Yes, yes.
It should be
Yes,
fine.
sir.
Is it coming now?
Yes, sir. Yes, sir. Yes, sir. It has come.
It has come. Okay. Can I go ahead now?
Yes,
Can
sir.
I go? Okay, fine.
Yes,
So
yes.
this is the recent advances in the treatment of Alzheimer's disease. I know I have only a short time because I had to leave after this meeting for another meeting. If there are any questions, I'll be happy to answer them after this. So my topic will be on introduction, risk factors, clinical features, management, investigations, treatment, pharmacological, psychosocial conclusion, references. This is the outline of my presentation. As we all know, dementia is a neurodegenerative disorder characterized by significant impairment in one or more domain, complex attention, function, learning, memory, language, perception, and social cognition. It is also important that these cognitive deficits interfere with functioning in daily activities, and Alzheimer's disease is the most common subtype of dementia, as we all know. What is Alzheimer's disease? I'm sure you might have already discussed this, but a very brief bird's eye view. Dementia is an umbrella term used to describe a range of symptoms associated with cognitive impairment. Alzheimer's is 50 to 75%, vascular is 20 to 30%. Dementia with Lewy bodies about 10 to 25%, and frontotemporal dementia is about 10 to 15%. And we know this gentleman, Alzheimer, reported a case in Germany in early 1900, and later named after him by Kraepelin. And as we World Alzheimer's Day is in this month, 21st September. So just a few words about Alzheimer's disease by way of introduction. It has an insidious onset of memory and cognitive impairment, gradual progression of symptoms, impairment of activities of daily living, no physical signs or new neuroimaging or laboratory evidence of other diseases that could cause dementia. If there are such findings, then the diagnosis should not be dementia and should not be Alzheimer's disease. It should be something else. So the types are early onset is below 65 years and late onset 65 years. It can be also that there are certain types which are familiar disease and also sporadic disease. This is the risk factors of Alzheimer's disease. I'm sure the one thing we can do is to take care of some of these risk factors. Age, genetics, and family history. Of course, we can take toxins, viruses, prions, then cognitive ability that we have to increase what we call some of the life skills, cognitive, you have to enhance our cognitive functioning and increase our cognitive reserve. Head trauma is harmful. Blood pressure should be within our normal limits. Aging, of course. But of course, what we can practice is healthy aging. Heart disease has to be taken care of. Lower level of education. Education has a protective factor. Physical exercise, again, protective. Diet, healthy and balanced diet is protective. Diabetic control of diabetes is very important. Of course, there are other factors like genes, of which we have very little control. Chromosome 14, then Down syndrome, chromosome 21. And these are some of the things of which, unfortunately, we have no control. And some of the clinical features are memory deficits, mainly for recent memory, but later for remote also. Naming and word finding difficulty, eccalculia, there is difficulty to calculate, aphasia, difficulty to speak, agnosia, to recognize, apraxia, to make skillful movements, geographical disorientation, and impairment of executive functions. And then, of course, we have the behavioral symptoms, which are depression, prosopagnosia, which is inability to recognize one's own face. You will, after a time, a person with dementia will not be able to recognize himself. Agitation, catastrophic reaction, there is a sudden breakdown following realization that they are not able to perform their regular tasks. Then psychosis, delusions, and hallucinations. So these are all well documented. Now, because my topic is management, I will come straight to management. So this is because we are mentioning about WPA. Recently, WPA had a conference, of course, before the onset of the pandemic. This ancient city of, I'm sure some of you can recognize the city, ancient city of Athens, where we discussed precisely this management of dementias, recent advances. So in the management, we will like to think of whatever useful investigations, cognitive function tests, Montreal Cognitive Assessment, and then mini mental status examination, MMSE, are useful ones. We have to rule out other causes of cognitive impairment, functional and structural MRI abnormalities. For example, cortical thinning at the earlier stage and reduced hippocampal volume. Then, of course, PET, increased Pittsburgh compound B, elevated mean cortical binding potential, amyloid load, FDG, etc. And the CSF can cause decreased amyloid beta levels, and then elevated levels of total tau and phosphorylated tau proteins. And treatment, of course, is pharmacological and psychosocial. In fact, I should actually start with the psychosocial because I am a social psychiatrist. But since people are more oriented towards pharmacological treatment, I will mention that first, but psychosocial has got a profound role, especially for the nursing professionals. The pharmacological management, because we should know this because people will be discussing with us and also asking for us some of the, what are the drugs available, can something be done, can we import medication from America or Gulf? So we would like to answer these questions so that we need to know what are they. So the cholinesterase inhibitors, donepezil, rivastigmine, galantamine, donepezil, we use extensively in our department as well. And the NMD agonist, memantine, all of these drugs we use. We mostly use donepezil and memantine in our department. As you see, the first three are for mild cognitive impairment, mild moderate dementia, and standard and first line treatment. And the memantine is for moderate and severe dementia. And donepezil has been recently approved for severe dementia as well. And we must also know the adverse effects. The cholinesterase inhibitors can produce gastrointestinal adverse effects such as nausea, vomiting, diarrhea, and abdominal cramp. And the NMD antagonists and can produce dizziness, headache, and confusion, and rarely agitation. For moderate to severe dementia, a combination of donepezil and memantine was found to be effective. But always keep in our mind, we must keep in our mind that our treatment should not be worse than the endurance of the disease. Sometimes patients do not need so much of medication, but they may not do well with, they may not show any good improvement. So in that case, our emphasis should be on psychosocial management. Treatment of the behavioral and psychological symptoms of dementia is extremely important. We call it as the BSPD. Depression in Alzheimer's disease dementia, serotonin reuptake inhibitors are preferred, very commonly used. Also we use mirtazapine, venlafaxine, and duloxetine and bupropion. The psychotic symptoms and agitation and aggression can be controlled with atypical antipsychotic drugs like olanzapine, risperidone, quetiapine, ziprasidone, and aripiprazole are preferred. But use has been controversial due to cerebrovascular morbidity and higher mortality. Of course, very used with caution. Should not prescribe antipsychotic drugs without discretion. Benzodiazepines are used to reduce agitation and anxiety, and anticonvulsant drugs like carbamazepine and sodium valproate are also useful. Then disease-modifying approaches to Alzheimer's disease is very important. Amyloid beta and tau are prime targets for disease-modifying therapies in Alzheimer's disease, decreasing the production of amyloid beta and tau, preventing aggregation or misfolding of these proteins, neutralizing or removing the toxic aggregate or misfolded forms of these proteins, or a combination of these modalities. Other targets are inflammation, oxidative damage, ion, and cholesterol metabolism. Then other anti-amyloid aggregation agents are anti-amyloid aggregation agents, tramiprosate in phase 3 trial, colostrenine in phase 2 trial, inositol in phase 2 trial. Of course, none of these drugs are available, but since we are thinking about recent advances, I'm just making a mention. Drugs interfering with metals involved in aggregation of amyloid, like zinc and copper, cleoquinol, and selective amyloid beta 42 lowering agents like beta secretase inhibitors, gamma secretase inhibitors, and alpha secretase activators. So these are some of the recent approaches. Amyloid beta degrading enzymes, neprilysin, NEP, insulin degrading enzyme, IDE, plasmin, endothelin converting enzyme, ECE 1 and 2, and angiotensin converting enzyme, ACE. And then, of course, immunotherapy, vaccination, bapineuzumab, solanezumab, aducanumab, and IVIG. So these are some of the things in the pipeline. Then anti-inflammatory drugs, long-term use of non-steroidal anti-inflammatory drugs, antioxidants, mitoquinone, vitamin E, ginkgo biloba, natural polyphenols such as green tea and wine, gamma fatty acids, folate, vitamin B6, and vitamin B12 supplementation. Of course, we must not be taken away by all these proposals or all these. Many of them are under research and only for our academic. But some of these are for our future, and let us be hopeful that there will be some agent which will be able to help the management of the dementia. Then we also think of a new tumor necrosis factor inhibitor, etanercept for perispinal injections, amyloid beta fibrillation inhibitors, glycans, cholesterol lowering therapy, statins, estrogen supplementation, selegiline, monoamine oxidase B inhibitor, citicoline, CDP choline, citidine 5-diphosphocholine. Again, many of them are experimental approaches, and we have very little experience with these drugs or agents. Then peribidil, D2, D3 agonism, methylphenidate, melatonin, nicotine. That's why some people are saying that smoking can help management of dementia. Of course, although it's not scientifically validated. Bexarotene, a retinoid X receptor agonist to enhance ApoE4, and cell transplantation and gene therapy. Then this is very important for all of us, especially for the nursing professionals. Psychosocial intervention. It's a broad term used to describe different ways to support people to overcome challenges and maintain good health, good mental health. Elements of intervention include prevention of behavioral disturbances, accommodation, flexibility. Psychosocial interventions can help with coming to terms with the diagnosis of dementia. Of course, we have to deliver it in a manner in which it is not traumatic to the patient as well as other people. And I would like to tell you that sometimes it is the nursing professionals who are going to communicate the diagnosis of dementia. So I'm sure you should be, all of you are well trained, because at the same time, we have to communicate effectively. At the same time, we should not destroy the patient's hope by saying that it's an incurable disease or there is no hope. No, there is every form of hope and there is form of interventions available. So we have to, at the same time, we have to tell them the seriousness of the illness. Maintaining the social life and relationships. People should be encouraged to do that. Reducing stress. So that we must help the patient and the relatives to reduce the stress and improve the cognitive function. So cognitive function can be improved by various cognitive enhancement method, which I have mentioned about earlier about cognitive reserve and living independently. Many people have to live independently, so we have to help them. And above all, quality of life for the people is very important, and reduce caregiver burden. And especially these in countries like India or low and middle income countries, the caregiver burden is severe and it is not being addressed to. Many times the family members are left to fend for themselves. I'm sure we have an obligation as health professionals to reduce the caregiver burden. For example, if we have a person with Alzheimer's disease, if we can have a voluntary, say for example, we go and stay with the patient for a day on a Sunday or on an off day and tell the carer to take a leave, go home or go for a cinema or enjoy. So that's the type of care, reducing the caregiver burden. It's not giving a lecture like what we are doing. we have come into the field, and this is a lot of work can be done by the non-governmental organizations and the other professionals. And strategies are patient's environment is safe, calm, and predictable. So predictability of the environment is very important. For example, you keep the telephone, mobile phone at the exact place. We give the calling bell at the proper place, and we also give the light switches and fans. So the patient, the moment once they started losing the memory, they'll find it more and more difficult. And then removing environmental stressors. They should be insulated from stressors as far as possible. For example, we may have a flood, we may have a COVID disease, we may have financial distress, but they are not going to be troubled with all that. It's better that we keep them insulated from all this as far as possible. Identify and avoid situations that agitate and frighten patients. We have to really be careful and considerate to them, and structuring the environment, facilitating activities, monitoring pain, providing stimulation, social contact. Social contact should be encouraged by encouraging, this is of course the time for social physical distancing, but it's not the time for social distancing. We don't have to have social distancing. So we can ask their children or grandchildren and relatives to call them on phone or WhatsApp or Zoom, or keep in touch with them. And then other psychosocial intervention, stress, anxiety, and depression should be taken care of. Cognitive behavior therapy helps them to learn new skills to cope. Psychotherapy, the formal psychotherapy may not be possible, but supportive psychotherapy is always possible, to discuss with them, to share their anxieties, to give them hope, encouragement, reassurance, guidance, help, support. Then stress and anxiety management. Of course, they have so anxious, we can give some mild anxiolytic drugs. Stress can be, you can help other people to share the stress. Family therapy, which involves the family members. Some of the family members may be agitated, bring them in. Animal assisted therapy is very useful, especially in many Western countries where the dogs, pets are brought in, and it's an important way of keeping touch, reduces loneliness, encourages to engage in physical activity, leisure and relaxation, and support group. We have many support groups like the Alzheimer's and Related Disorders Society International, of which I have been associate for 2-3 decades. They are doing a tremendous job. And then improving and maintaining cognitive functioning. So that is assistive technology, communication aids, that GPS trackers, video conferencing, medication monitor or alarm. So let us not think that video conferencing only for us, but they can also be helped, and they can also be assisted with all these modern technologies. They can be encouraged to use Facebook or Twitter or WhatsApp. And cognitive rehabilitation, learning strategies for managing memory problems or better ways of tackling everyday tasks. For example, even simple thing like asking them to note down what they should do every day in the morning before they forget. For example, if somebody may make a telephone call and ask them to call back, which they often likely forget. So helping them to note down are simple strategies which can be very helpful. Then psychosocial interventions, cognitive stimulation therapy, make most of the skills and mental health functions through exercise and activities, which helps to slow down cognitive decline. I would actively encourage about 40 minutes of physical exercise, if possible, walking, brisk walking, and that will be very helpful, and involving games, singing, reminiscences, sharing stories, chatting and discussions, current events, arts, crafts. I have visited some of these facilities in various places. Our own World Psychiatric Association's headquarters is in the Geneva University Hospital, where they have reminiscences therapy, where they come and then their marriage video is being played, or their baptism of their child, or the breakup social of their college. They're all suddenly bring cheer and pleasantness to them. So these are some of the things we should do. Cognitive training specific aspects of memory and other thinking skills, brain training, games and puzzles. Occupational therapy, they should not remain idle. And some of the women are very good in embroidery or tailoring or making some baskets or which can be, we can promote the sale of it through our own outlets. Reminiscences, remembering, retailing past events and memories of life, create life storybook. So this is all very good. And psychosocial interventions, help for families and caregivers, assisted technology, cognitive behavior therapy, psychotherapy, address depression, anxiety, and burnout, psychoeducation, family therapy. You must always address the history, the burnout in the carers, where burnout is a sense, when they're burned out, they have a sense of lack of accomplishment and sense a complete disinterest, and they feel they have no role to play, and they may mechanically carry on. So we must prevent caregiver burnout. That should be one of our own important strategies. And maintaining quality of life, animal-assisted pet therapy, creative art therapy using media such as painting, literature, sculpture, and music, opportunity to express emotions as well as intellectual stimulation, music therapy, playing good music, especially the old music, maybe some of the some Yeshudas or Lata Mangeshkar, or all the such people of olden times. Aromatherapy, maintain sense of identity, augmentation of sensory abilities, better fitting eyeglasses, auditory amplifier, hearing aids, and these are, if you can guess, these are the articles of the Mahatma Gandhi, which are sold for millions of dollars. These are very simple things, but they are so valuable. So this is similarly our psychosocial interventions, which I just mentioned. They are in fact more valuable than the medications. Of course, medication can produce some relief, but really there is no cure now. And what is psychosocial interventions can make a dramatic difference. And we have been working on this area. This is one of the workshop on mental health and older people, which we did in Medical College Kottayam with the University of Wolverhampton in UK. You can see it is about 15 years back. And of course, our colleagues from the nursing profession have always been with us. You can see on the extreme Dr. Varghese Punus, who is the current HOD there. And this extreme is Dr. Sadish, who is the current principal of the Kochi Medical College. So all of them are involved. He is professor of old age psychiatry from the UK, Tony Elliott. So we have been doing this for a long time. I'm very happy to share these things with you. It is difficult to be a psychiatric patient or Alzheimer's patient, but a good mental health professional, all of you, can make it less so. Resistance to treatment is amenable to intelligent persuasion. So you think our Alzheimer's patient is not going to listen to us. Intelligent persuasion makes all differences. Confusion and fear can be overcome by knowledge and compassion. So that should be the watchword: compassion and intelligent persuasion. And in conclusion, I would like to say that Alzheimer's disease increases with increasing life expectancy in the community. Kerala has one of the highest life expectancies in the country, almost similar to the Western world, 75, around 75. So this is a real problem for us. But Kerala is a model for healthcare, so we have to find out innovative strategies. No definite way of prevention. Effective early diagnostic tools and efficient ways of treatment are not available, despite availability of advanced neuroimaging technology and neuropsychological evaluation tools. So they are not available. So there is a need for simple, easily available, sensitive multimodal biomarkers for early diagnosis as well as effective disease-modifying pharmacological agents. A new look is needed for both diagnostic and therapeutic point of view. And thank you very much for the patient hearing. Yes. Thank you.
So there is a question for you from Ledda Murthy. Please specify any special kind of activities or games for Alzheimer's patients at home setup.
Okay.
You have already mentioned some of the activities.
Yeah. So they are asking about home setup. Okay.
Yes.
For example, if there are activities which involve physical as well as mental exercises. For example, even a simple exercise like card playing cards with older people. Now there are, or you can have an outdoor exercise like a small badminton games if you have the facility, or a table tennis at home if you have it. and even running around, small, even with children, grandchildren, they're all very effective. And these are some of the things we can always do. Puzzles or crossword puzzles, everything can be very helpful. Thank you. Are there any other questions? I think there are some. Can you please explain areas, criteria that takes that is for
One more.
not for
One
me?
more.
Okay, please.
One more question for you. I think it's how the family members will recognize Alzheimer's client health education for family members.
How the family members will recognize Alzheimer's client and health education for family members. They're very, very good questions. And I'm sure one of the first signs of Alzheimer's disease is loss of memory. And the family members will be the first one to note. For example, sometimes they forget, for example, a visitor has come home for inviting for a marriage, and only the adult person with early onset Alzheimer's disease, they simply forget. Or they might forget that people have telephoned. For example, if I come home and I'm told that information is not given to me. So these are earlier signs that my father, my mother, or my relative is getting early Alzheimer's disease. There are some of the early signs. And once it worsens, they start forgetting even bigger things, like they sometimes forget that they have taken the breakfast. After taking breakfast, they will say, well, please serve me the breakfast. And once you say that they have already taken breakfast, they become very angry because they think the breakfast is not taken. So, and then family members have to be told that whenever is suspicion is there, please take them to a mental health professional or at least a GP, a general practitioner, who will help them to make a reference. If the GP says nothing much need to be done, you can stop there. Otherwise, you have to go to a mental health professional like one of us or our department. So where we will provide a comprehensive therapy. And if we need it, then we also refer to a neurologist for any supportive care if needed. Basically, it is going to be a biopsychosocial approach, which is necessary for the management of Alzheimer's disease. At the same time, we have to take care of the family members by reassurance and guidance and helping them. Thank you.
And I think one more question to you. So can you mention the specific diet which must included for the patient?
Specific diet, okay. I would say what we need is a high fiber diet is good for everybody. There is nothing like a anti-Alzheimer's diet, but a balanced diet, especially high in fibers. And if I am asked to recommend, I would say high fiber diet is a lot of fruits, and then any type of fruit. Especially if you are not a very diabetic, then common things like a lot of vegetables, which have got a lot of fiber, and then then things like oats. They are all very good for health, and this can be very useful. But lean, like for example, the common food items in Kerala like parota or I would say chapati, they are not very, very useful. Or plain bread, they are not very useful. Yes.
Thank you, sir. Thank you.
I think that session is over. I know, sir, you are a very busy person, but thank you very much, sir, for spending your valuable time with us and sharing the deep knowledge about recent advances in the treatment of Alzheimer's disease with us. It will be a great pleasure for us to listen to you again in our future events. We'll move to the next session.
I'll be here for some more time, but in between I'll be leaving for another meeting at 12 noon. Thank you very much. Okay.
Okay, sir. Thank you very much, sir. It gives me immense pleasure to invite a very vibrant and dynamic personality for the next session, Dr. Reena George, Assistant Professor and Head in the Department of Psychiatric Nursing, Institute of Mental Health and Neurosciences, Kozhikode. Madam pursued PhD from Bharathiar University. Completed MSc in Psychiatric Nursing from Father College of Nursing, Mangalore. MSc in Applied Psychology from Annamalai University. PG diploma in counseling from Europe, and certificate course in family healthcare from Kerala University of Health Sciences, Thrissur. Madam has many publications in national and international journals to her credit, and a resource person for many workshops and conferences. Areas of interest are qualitative and mixed method research, palliative care, hardiness training, community mental health, stress management, family health, public education, mental health of adolescents and women. Currently serves as member of Border Studies, Nursing at Kerala University of Health Sciences. Has 3 years of clinical and 14 years of UG and PG teaching experiences. Over to you, madam.
Thank you, Vinita ma'am. Shall I start? Am I audible?
Yes. You
I
are
have
audible.
already shared my slide. I think you can see it. Can you?
Yes. We can.
Shall I start there? Okay, at the very
Yes.
outset, let me thank the organizers for rightly perceiving the topic and giving me a chance to share some thoughts with you all. We were hearing the speech from two eminent personalities, so I will try to avoid any duplication of that. So I would like to draw your attention to a news which is published in the Hindu during 2016, and they have noticed that there are few facilities for dementia care in Kerala. On an Alzheimer's Day, it has been published, and they quoted some studies and shows that according to an estimated 4% of those above 55 in the state have some form of dementia, including Alzheimer's. And this also they have given in the newspaper a good news, like the Kerala State Initiative on Dementia Care was launched by the Social Justice Department with technical support from Alzheimer's and Related Disorder Society of India, ARDSI, with focus establishing social support system and care facilities for those dementia. This was a good news during that time. And my presentation is going to touch all these areas like healthcare delivery system facing the challenges and issues due to Alzheimer's disease, the individual, family, society, all of them, what they face as a challenge to treat patients with Alzheimer's and what can we do. This is a content which I am going to present. So when we are thinking about healthcare system, we know that a study published by Kuhn in 2009, he has mentioned older adults with dementia and including Alzheimer's, when compared with the normal adults, they are 3 times more hospital admissions are there, and 21.8 times higher hospital cost, 3.1 times higher home health cost, 2 to 3 times length of hospital stay. So this is the burden of our healthcare system to manage this issue. And not only that, when we are considering there are problems with caregivers, healthcare system, society, but just think about the individual first. So individual who is really experiencing this, he will be always searching for the memory which is lost. So like the picture you are seeing, an adult struggling to push that stone, the individual also will be struggling. So he will be showing the frustration, agitation sometimes. So we have already heard of all these lobes it is affected. But when considering what will the patient's behavior, like putting underwear over clothing, just imagine the person who is doing this type of behavior will be humiliated highly by others, and people may laugh at him who are not aware of this disease. So eating from another's place, cursing, or like spelling hell, swearing, inability to identify spoiled food by smell, inability to sense one's skin is burned, difficulty orienting body to or asking questions over and over, sudden reaction to minor events with episode of rage, may not recognize spouse, may be afraid of the spouse, thinking that a spouse is a danger to him, unable to recognize what is not food. Common features are this, and sometimes patient will land up in hospital with eating non-eatables. Like one example I do remember, when I was working in a clinic, a patient has brought there, a patient had taken the mosquito repellent biscuit shaped one good night, thinking that this patient, it's biscuit. So sometimes it can happen because they don't know what is eatable and what is not meant for that. And always the short-term memory loss, as sir has mentioned, there are different stages, and need in this all stages are different. So based on the patient's condition, the caregiver should be vibrant enough to produce the care, like based on the necessity of each need. So here, why they need specialized care? We know that generalized loss of memory and cognitive thinking, so they need assistance everywhere in their life. So sometimes their mood changes may be very fast. So suddenly they will swing from one mood state to another mood, and disorientation and general confusion may be there, loss of ability to speak or hold conversation, difficulty walking, soloing, inability to recognize people and persons, place, so highly disoriented at times when the later stages of Alzheimer's, inability to participate in activity, including personal care and requirement daily life. So worsening of all symptoms over time. You know, all these are basic need of an individual. Individual is what individual wishes to do it by himself or herself if there is strength. But most of the time, this will not happen with our patients who are experiencing Alzheimer's disease. So what will happen? They themselves are frustrated, and they have to be highly dependent on somebody else. That itself sometimes causing distress in the individual. So it's a challenge to live with dementia. So uncertainty about the future. We know whenever we are suffering with some illness, including COVID, we can understand there can be recovery. There is a chance to come back to the normal stage, or at least near normal. But here the deterioration is going on. So patient or patient's family will have uncertainty always. So we can't say that tomorrow he will be all right. So or this problem will get over. So that hope we also are not able to give sometimes. So we have to change our style of educating the patient to maintain what he can or do what he can. So always focus on solutions than problems. So sometimes not knowing about the future and how symptoms will develop can be unsettling for anyone. And mild memory problems, depression and anxiety, a lot of studies are there, depression and anxiety among patients and caregivers, healthy lifestyle changes in behavior, all these are challenging for a patient who is experiencing Alzheimer's. So this is the first what family caregiver face. When you start searching for Alzheimer's, all the studies or most of the studies are coming with regard to the caregiver, like a caregiver burden, caregiver coping styles, caregiver stress, caregiver anxiety, caregiver mental and physical health. Everything is listed and tested by most of the people, most of the researchers. You can get it very well. You can search it. So why they are facing challenge is there is progressive biological brain disorder in their patient and more difficult for them to remember things, think clearly, communicate with others, take care. So these patients are not able to tell their need to others. For example, if ants are moving through the bed, naturally we will be understanding and we will be telling the caregiver. This patient sometimes may forget or not able to communicate their needs. So sometimes what will happen, we will be knowing the patient is in the later stage of skin decubitus ulcer or something. Or this all happens. So highly they are dependent on family caregiver is a burden for the family caregiver. Family caregiver has to spend a lot of time with the patient. So they are also challenging. And some of their challenges are managing their time. You know, the family caregiver, you just visit any home where there is Alzheimer's patient, just talk or look at the face of the family caregiver. You can understand that they will be very tired, fatigued. Like initial stage, they will be okay. But most of the time, they don't have time to take care of themselves. Even I heard some of them speaking, even they are afraid to go to bathroom and take bath, closing the door when patient is their relative or father or somebody is there at home with Alzheimer's disease, and they open the door and take bath, thinking that this person may leave home in their absence. So that much struggle they are facing. And emotional and physical stress is another. Lack of privacy, financial strain. You know that these medications are expensive at times. Only the person, well-to-do persons can give medications to the patients or assign a caregiver to take care of the patient. It's a tough time to assign somebody else for the patient. And sleep deprivation, most of the time the patient's sleep is disrupted and patient will get up in the middle and call them. So caregiver also have to get up whenever patient demands him or her to stay with the patient. So sleep deprivation is another issue. Being afraid to ask for help, depression and isolation. So just imagine the same environment the caregiver also shares with the patient. Only thing, patient is experiencing illness and caregiver does not experience at the moment, but the same condition, the environment is same. Sometimes the genetical environment is same if related. All these things are influencing the caregiver. And when coming to how can we, I'm not touching all the area in this short session. So just some of the important points I'll touch, how to take care of the what others have not taught, only that. So if we care the patient in institution or home. There is no much difference because one person will be there or paid caregiver is there at the institution and caregiver may be free of stress. That's our family member will be free, relaxed. That may be the only advantage. Otherwise, the institution care and home care is having not much different because why is home also should be considered like an institution because always the caregiver should be 24 into 7 hours. The caregiver should be available for the patient. So not like other disorders. Once you are recovering and sending patient home, discharging with all the hope. It's not like that. The caregiver also have to act like a paid or professional caregiver. So prevention of injuries, how can we manage? Usually these injuries are related to disorientation, confusion, weakness, muscular incoordination, memory impairment, poor vision, extreme psychomotor agitation. This may lead to injury. So what we can do to prevent this? Like assess level of disorientation. You may think how a home person or relative can assess disorientation. You have to train them. The competency of the caregiver has to be somewhat equal to the competency of the professional. Then only we can prevent injury. So teach them how to assess disorientation. There is a hobby of family members and friends to come to the elder who is experiencing Alzheimer's and ask, Appa, tell who am I? Do you recognize me? And this, the person understand, the person with Alzheimer's understand, he don't remember. What will happen? Their stress is increasing unless you go to the patient and tell, I am so and so, I am your relative. Today is Monday or this month is this. So tell them the information than asking them like Viva. Just imagine somebody asking question to us, how frustrating it is. Then what about a person who can't get memory? So interacting with this, if at all some relative visit home like that, the caregiver has to restrict them and tell them, Appa or Amma is a little bit not okay. Don't ask such questions. You can visit and greet him and come. So we don't bother about others. We have to bother about our patient, and that's our important issue. Sometimes we have to argue with others. Just forget when we have to have this type of care. So arrange furniture in room that we accommodate client disability. We like to decorate our room with many furniture and we make clutter the person's way. Person can't go. Today room was arranged in particular way. Tomorrow some relatives are coming or visitors are coming. We are arranging them in different way. This will frustrate the person with Alzheimer's disease. So the person's movement should be free at home. Frequently observe clients' behavior on one-to-one basis. This is very difficult, but if at all possible, do it. Then only we can prevent injury. Assess client when ambulating. The person will get up from the bed and walk. The person was usually doing that before. So they don't like to lie on the bed always. So if at all they are getting up, ambulate, when trying to ambulate, be with them. Use wheelchair for transporting long distance. Most of the elder will tell us, no need of wheelchair, we will walk, we are able to walk. That is their confidence. But after 2-3 steps, they may fall and the caregiver is standing with the patient, may not be strong enough to hold the patient and it can cause injury. So avoid problems, expect problem always and avoid it. That's the best treatment for avoiding injury. So use wheelchair if you want to move patient through the garden or to the courtyard. Then store items that client uses frequently with easy access. So client will have attachment to his towel, his all things, his all whatever favorite to him sometimes, like his particular blanket. So it has to be kept in his easy reach and remove potentially harmful object. Especially we have seen that these patients are holding cigarette in the hand, sometimes smoke, and the hand is burned and they are not able to recognize it. So cigarette, matches, light, sharp object, all this we may think what's there, he's an adult, but consider how we are preventing accidents in toddler or children. Same way you have to consider them and keep all the harmful objects away from this, especially nail cutter. They will try to cut their nails, including the flesh. Most of the time this happens when patient comes to the hospital, they come with this type of injuries commonly. Remain with the client when he or she smokes. As I have already mentioned, part side rails and headboards. Recently I met one of my teacher and she has told her mother-in-law is having this Alzheimer's disease and they have modified their house. And she has, in joke, she has told me, we need this in future also for us. So I felt to salute her because doing a lot for our elder, so that she had made some rails to move to the toilet. The patient is in the initial stage, okay. Then padded that bed headboard of the patient and side rails are kept for the bed. They are preparing the patient and If patient is comfortable, it's good for us. We don't have to run behind to manage injury. So it's ultimately it's help for us only. Client, if open to wander, provide an area for wandering. So when we are preventing and tying them, they will what to say, express their anger because they want to walk. Remove all the furniture from the room. They give them time, place to walk, or allow them to go to the courtyard if okay and stay there. If garden is there, let them move, stay there, prevent injury. If wandering is prevented, the person will have more aggression. So better to, I don't know how much it's possible because in flat 1 or 2 bedrooms, it will be difficult, but still let the person move in the room. So you don't think about the beautifying of your house, just forget, give importance, priority for what is essential at home. So frequently orient to the reality and surrounding. Sometimes patient may tell that, oh, it's a time to go to church. At the midnight, patient will put, I do remember one of my friend's relatives, she used to get up in the midnight and put chatta wall veshti and tell, we'll go to church, the bell is ringing. So we have to orient, it's not the church time, it's midnight, bell is not ringing, it's clock ticking. So orient them, don't tell that, oh, bell is ringing, so we will go. Some people will speak like this, don't ask, don't encourage their perception, wrong perceptions. Prescribe use of restraint tranquilizers. Already, sir has mentioned the medicines. If at all prescribed restraints usages, there are legal issues, legal restrictions, if at all, so use of and as prescribed if tranquilizers. Training for caregivers, I assure you that you have to train your caregivers to prevent injury. You don't discharge patient from the hospital and saying that you take care, okay. No, never assume that. If at all it's a healthcare professional, never assume that they are expert. Just tell, repeat. So, and another issue is self-directed or other directed violence. Sometimes patient harm himself, not intentionally, it happens. Sometimes violence at others. So how can we understand? Look at patient, rigid posture, clenching fist, jaw. Patient will be like a sumo gusti person getting ready to attack. So breathless, threatening posture, suicidal plans, cognitive impairment. All this you have to see as a signal for patients violence to self-worth. So what we can do, assess level of anxiety. Most of the time anxiety is inducing this type of behavior. Anxiety, the caregiver, home caregiver are the better person to understand the person's expression of anxiety or when they are okay. So any changes happens, they should be able to identify and maintain low level of stimuli in room. Don't give bright light in the room which is irritating patients. Simple decoration, low noise, few people. Don't allow visitors to come then and there and see the what happens and they make jokes. So don't allow visitors. Patient is not an animal to watch by everyone. Understand that patient has to have his own privacy, though he is affected by this disease. Have sufficient people for help. Don't feel that you can manage everything and your hand only will do the wonders. Ask for help. Delegate responsibility to a trustworthy person if okay. Maintain calm manner. Interrupt period of unreality and reorient. Sometimes unreality periods are there. Just interrupt it. Patient is telling that I'm hearing somebody is talking to me. I'm not hearing. Just sense that doubt. Tell that I'm not hearing. So person will think, oh, you are trustworthy person. He's not hearing. No, it may not be real. So sometimes reorient person. So every time when you go to patient, dad, it's time for lunch, or it's midnight, it's morning, right? Orient to the person. So, and I will tell you how to keep the rooms with some necessary items. Teach relaxation exercise. Teaching is how much possible we don't know, but try to tell them to relax. And training for caregivers. Some persons will be happy to go back to their past hobbies, like if they are like the music lovers, they like to listen. Ask their past hobbies, not our hobbies. Sometimes we like music, we play it. Not that. You ask, do you like to hear some music? Yes means do. Some there's elder women may like to hear some prayers, some chanting of mantras. If it is their wish, just play for them. Training for caregivers, again I say, to how to avoid violence. Then chronic confusion, already I have mentioned, but some more points, like frequently orient reality to and surrounding, allow client to have familiar object around him, use clock, calendar, daily schedule to assist easy. So if you are keeping clock with the big hands, written, the letter should be big enough, big clock, The person can hear the bells or person can see the time placed. No, it is placed for the direct vision of the patient. Patient don't have to turn the neck and get sprayed. Don't keep like that. So person's bed, it has to be facing the person's bed. Orient to time, place and person. Give positive feedback when behavior is appropriate. Sometimes patient may be tell, it's a time for breakfast. Can I have something? Oh, it's good that you have recognized your time for breakfast. Very good. That way reinforce the person. And use simple explanations and face-to-face interaction when communicating with the client. So patient is asking, why do I need insulin? We tell it's prescribed by doctor, you have to take. Patient will tell, I don't want. How can we tell? This insulin is a hormone which lacks by your body. You need it. Your body needs it. Tell them in simple way. So they will tell, oh, my body needs it. Then give me. So you should know the technique to reach to the patient's mind. Express reasonable doubt if client displays suspicious beliefs. Do not permit rumination of false ideas. Sometimes person may tell, yesterday when I tried to sleep, last night, some people were standing here, they were trying to attack me. This type of stories patient may create, and you will be reinforcing, asking how many people were there. Oh, they tried to attack. What was there in their hand? We tell you there is no chance. You are in a protected, safe environment. There is no chance for getting this type of situation. So don't give again and again. They may repeat. This is called rumination. Same thoughts are repeated. Don't encourage this. And so, of course, self-care deficit is there. I have told all the 4 lobes of brain may be affected and person is not able to take care of himself. So identify self-care deficit. You have to say whether any patient have started with a decubitus ulcer or any assistance required. You should recognize some cues from the patient. For example, if the person is licking lips like this, the throat may be dried, need water, not able to ask. Oh, Appa, you want water. Same way you have to recognize and ask. And when person is lying down, don't pour water into his mouth. Just make the person sit and give. So prevent problems. Guidance and support. Whenever you are guiding the person, supporting the person, teach them one step at a time. And to speak one step at a time. For example, if you want to communicate to the patient, shall we take kanji or gruel? That's a question. Don't tell, Appa, we are going for bath. After that, we will have cleaning yourself. After dressing, you are going to have that. Why are you speaking long sentence? Just break the sentence. What you are going to do that time, that only you indicate patient. And structure schedule of activity. Keep in patient's room the schedule of activity, like what is next. Early morning, they are getting up. After that, brushing. After that, they are eating breakfast. All these type of schedules have to be written for the patient, and it's easy for the patient to follow it daily. How much ever possible, let the patient do. Don't be so rigid. Like sometimes you have to be flexible, but still, if it is pasted on the patient wall, he will understand. Oh, this is over. Next is this. Sometimes, so patient will have some idea. And ensure activities of daily living for home routines. Sometimes the therapist will write down and give some routines. It will be entirely different from home routines. So sometimes patient is sleeping at 10 o'clock. You are telling family is sleeping at 8 o'clock. We are telling you go to bed at 10. So sometimes our plan and patient's home plan may not be realistic. So most of the time it has to follow home routines. It's not disrupting much of the family routines. Train prospective caregivers. Again, I say if patients bystanders are there, somebody is taking care of the patient. If you are thinking that they are prospective caregivers, please encourage them to undergo training, short training. Then a structured schedule of activities, ensure activities to follow home routines, train prospective. I already told. Another thing is disrupted sensory perception. Teach prospective caregiver how to recognize signs and symptoms of inaccurate perception. We know that when patient is hearing sound or it's something inaccurate, they will respond. Sometimes they will speak without any persons. So thinking that somebody is standing there, or they think in the evening, if shadows are there in the room, they will cry bitterly thinking that somebody is coming to attack them. So you have to recognize their disturbed sensory perception and understand how to tackle it. Then low self-esteem is another thing which can be experienced by person with Alzheimer's disease. So encourage client to express honest feeling in relation to loss of prior level of function. You tell them you were having a lot of abilities when you were an adult. And when you are an adult in young age, now you lack some of this. Am I right? What do you feel so? If you are not able to remember, you are not able to recall your friend's name, are you sad on this? Or what can we do? Just show their photos or tell their names if you know, and encourage them to express their honest feeling and support in the process of grieving. Especially they have some grief related to their spouse death or some caregiver. Unfortunately, the caregiver is going away. That also a grief for the patient. Sudden change of another caregiver. Sometimes we have to stay with their grieving process. And so there are some devices for assisting client with the memory deficit. If at all any patients are there at home, family members can try to use this how much ever possible. Name signboard on the door of the patient's room. If patient's name is Joseph, and you can write Joseph's room or Achan's room on the door of the patient's room. So always patient doesn't have to search his room and walk. We may think it's very simple, but patient will understand, or paste his photo on his door. So he will understand this is his room and he will use it, open the door. And if at all he comes to the hall or somewhere, he will find difficulty to find his room later. So dining room door, label it dining hall or food time. So something you paste on the dining room, restroom. This is our restroom or washroom. All this you have to paste the label. We may think it's very unusual doing or something weird like, but for patient needs it. So large clock with oversized number and hands appropriately placed in the room, and large calendar. When we keep calendar, some days we ourselves are not knowing what's the date today. We may ask somebody, what's the date today? Am I right? So what we have to do, don't place all the dates in the calendar, only one date. Particular date. You might have seen in some shops that calendar, they are placing day, date and year on only particular days calendar. So removing or sticking daily calendar or removing the outdated days, so that you can use, and day and year identified in bold print. This type of calendar you can use in patient's room, particular only one day at a time, month, day, year identified in bold print. Don't keep our Malayalam Manorama or government calendar thinking that all this is decorative. Decoration is not necessary for our patient. He wants to be free from his illness or his uncertainty. So keep calendar. I have already told regarding the clock with big hands. News board on the wall. We may think what this elder want to know in this age or in the Alzheimer's. Don't have the notion. You paste some newspaper cutting on patient's room, like what happened in the local area. For example, COVID outbreak. So all have to do social distancing. All this type of news paste in patient's room in a bulletin board or something. They should have a board. You can keep their relatives' photo and all in that. This can give them a relief in their stress. That itself will help us. So current national and local events. For example, Trump is visiting India. That type of, oh, this is American president coming to India. He will ask questions based on that. Some stimulation of their thoughts. So encourage attempt to communicate. So they may move their lips. They want to speak something. That time we don't have time to wait and hear. We may think, we'll go. So ask them, do you want to say something? Okay, start. Give them sufficient time. So they should have a caregiver. Don't go for all the works. We have to focus on him, like how we are taking care of infants, babies. One person always will be there with them. Same way, our dad has or mom has taken care of us. Why don't we spare some time for them? If at all we are working, not having time, assign somebody. Okay, somebody else. So encourage reminiscence and discussions of life review and present day events. Some people will tell, when I was young, when I visited this place, I saw this. Only that they will tell. I saw a beautiful flower, somebody. I do remember a person, he used to tell always, I had a friend who liked white flowers. Only this much. Friend's name, he doesn't know what, only this white flowers. So you encourage it. Okay. Oh, you do, you also enjoyed that person's likeness. Okay, all this way you can. Another encourage participation group activities. Here in Hans, we used to conduct a group for patients. Nowadays, due to COVID, it's stopped, like because of social distancing. We can tell the family members to bring. Otherwise, if nowadays we can do through Zoom, but we have started with other therapies like for children, patients with disabilities, not reached to these people. We will be trying to do it. Encourage participation group activities, offer support and empathy when expresses embarrassment, then encourage to do possible independent self-care activities. How much ever they are possible, let them do. Sometimes we may force them to use bedpan. They don't like. They will tell, I want to go to toilet. It may be a tough time for us to lift this person and go, but if at all possible, help and let them go. Why are you forcing bedpan if the person doesn't like? That itself will create the person's anxiety. So if possible, independent self-care activities. And another, I have to speak a lot regarding caregiver role strain. You can search the studies, a lot of studies, thousands and lakhs of studies are there for caregiver burden, caregiver coping styles, caregiver hardness training, how we can make them hard, able to withstand, and caregiver stress management. A lot of studies are there. Please go through. Because I'm not able to speak everything in this time. So ensure available community support. Connect one person with another. So the person will understand, family members will understand, I am not only the person who is experiencing this, others also are going through. So we can hold hand in hand and discuss. So this person's symptoms will be similar, not similar to other person's symptoms, sometimes similar. So they can share some relief. Even connected through WhatsApp or phone, they can express their worries. So adult daycare centers are available, housekeeping and home care services available if at all. Help the caregivers. Caring the carers is very important. That is another area, caring the carers. Those who are providing care have to be supported by others. Sometimes only one daughter-in-law is taking care of all things and nobody else is bothered. They visit and complain that, oh, this is the way my dad is walking. Oh, dad is wetting bed, and that is easy for children to tell. Children to tell complaint is easy, but you should understand whoever is taking care is struggling. Every day's event is this. For us, it may be a momentary event to care and show that we are good. Don't go for that. Don't make frustration for the person who is caring the person. Understand, you have to care the carer. Understand, he is caring your person. So the person have to be supported. So local chapter of Alzheimer's Association, if any are there, you can. You will be, most of you are working in the mental health area, you will be aware of what is working in your area. Encourage participation in support groups, stress management techniques like journaling technique. Journaling technique for the caregiver. Tell the caregiver to write a diary or tell them to write whatever they want. So they will be writing. It's a journaling technique. Please refer, because you all are healthcare professionals, not going much into that. Journaling technique is a very good technique for managing stress. So they can write down their experiences, what all frustration they, and they can bring it to the doctor when they visit. I have this all doubts. What will happen? They will ask doctor some doubt, and later they don't remember what they wanted to ask. So journaling will help that also. So Jacobson's progressive muscle relaxation techniques are another one. And key challenges for fighting Alzheimer's disease. I told the challenges faced by individual, healthcare system, family, patient, all this, and what our country faces. We need to be addressed by the nation to combat growth and devastating impact of Alzheimer's disease. So Alzheimer's Association new report identified 10 critical challenges faced by the country, like lack of public knowledge. I told training caregivers, I was placed in almost all the slides. So public knowledge is not much with regard to this issue. Insufficient funding, poor dementia care, inadequate treatment, specific challenge faced diverse communities. So cultural sensitivity is very important. Culturally sensitive caregiving is a challenge for the country. Each culture is different in caring the person. So specific challenges faced by diverse communities, specific challenges faced by those with younger onset Alzheimer's, unprepared caregivers. Caregivers may not be prepared. Caregivers bringing the hospital first time, patient to the hospital first time, thinking that can discharge and go relaxed. But they are getting a note, actually it's a breaking bad news, like your dad is not going to improve, deteriorating in future. So you have to get prepared. It's not a good news for the caregiver. So they are unprepared. So preparing them is challenge of the country. Ill-equipped communities, mounting cost of care. Ill-equipped communities, the community may not be able to identify this is the problem of this person due to disease. Community may tell that restrain this person, why he is disturbing, because patient is forgetting which is his house and entering another person's house. That is a distressing moment for the neighbors. I do remember a person who was a generous in giving and affected by Alzheimer's. At the end, he used to pluck somebody's fruits and he used to bring somebody's coconut from somebody's land, and they think he is a person thief, and they are thinking till today he was generous, and suddenly what he is doing. And they complained, community, society complained to family and asked, admit him in some mental hospitals. So most of the patients are directly coming to psychiatric hospital with the symptoms. So it's very challenging for us to see that it's not due to any other issue, it's Alzheimer's. So mounting cost of care is another. So All this is based on, this report is based on 43,000 people in 50 states, written by Puerto Rico and Washington. This is a study-based report. So this is a country, any country face these challenges. So developed and developing countries, it may be different due to the availability of resources, but we also face most of this. And you know that in 2016, our Right of Persons with Disabilities Act has come, RPWD Act, Right of Persons with Disabilities. There were only 7 disabilities and they have changed it to 21 disabilities. You can very well know from the sites, just type in the Google, Right of Persons with Disabilities Act 2016. And in that list has been expanded from 7 to 21 conditions. Just see the list. Cerebral palsy, dwarfism, muscular dystrophy, acid attack, hard of hearing, speech, language disability, specific learning, autism spectrum disorder, chronic neurological disorders. Just see, chronic neurological disorder is the term added for multiple sclerosis, Parkinson's disease, blood disorders, hemophilia, thalassemia, sickle cell, all this. But they have not mentioned the name Alzheimer's. We are not criticizing, but it's our duty to stimulate the government at least next time when revising, the name has to come. We know that it's a devastating neurological disease, but because the name is not mentioned, the patients may not get benefit all the time, because we know whoever is sitting in the office will tell this name is not mentioned. What can I do? They are confused. Sometimes it happens. So I have met many people yesterday who are working in the disability area, asked Alzheimer's added or not. They are telling no. So one study I have seen, it's added, but it was a perception of the researcher. When I checked, it's the reality. It's taken from directly from the PWD Act, Person with Disabilities. So we hope in future, the Alzheimer's disease also will be added in this. Mention the name like what other names it's written. It's there like neurological disorders, but as I have mentioned, name is not there. So how can we overcome these challenges? So a number of dementia apps are there. If you're able to do like in our age, if we get dementia, I think we are able to use technology. We have to hope for the Western world and get prepared. So there are some apps given in the sites like It's Done. It's Done is an app helping to memory and to-do list, helping this type of person. If anybody have memory problem, he can just download this app to help with the memory and to-do list, what to do next. We are keeping diary, when is our class, when is this, or reminder. Same way it's reminders. And jointly to stay connected with the loved ones. MindMate is to help with the cognitive functions. My Home Helper is to assist with independent living. Young onset dementia to help young people diagnosed with their symptoms. All these apps are available. And how much we are using is the question. How much they are able to use is the question. Sometimes caregiver will be able to use it and connect to the person. So break the dementia stereotype. People are afraid to say that my dad is having dementia or my neighbor is. Why don't we bother? Take dementia friends, like just forget the stereotype. Don't have that low, what to say, that we are giving more importance for what our name is. Just forget the name and work. As our Indira Gandhi once told, talk less, work more. So that only we have to speak. So just forget the stereotype, just forget the name of the mental illness and all. If somebody is there, get the treatment. That's the ultimate work. So how to avoid socialization, already discussion had over. So you can give them some puzzles like this. And don't be so rigid that they are, you help them. 90% you have to do, 10% they will do. You don't give them big puzzle and viva and written test. Don't do that. So don't make their, you are there to relieve their stress, not to increase their stress. Our principle is do no harm. Though we can't do anything, do no harm. So how to maintain interactive lifestyle? So many researchers are showing that people living with dementia and Alzheimer's have been passive most of the day and not interacting with the surrounding. So sometimes they have to be oriented to the surroundings, and most of the time their problems are there with the managing finance. So this is the advertisement I have seen by HSBC Bank. I'm not the promoter of that. Please don't think like that. They are thinking, they are advertising, they are using voice technology recognition for patients with dementia. Like they are mumbling words, no need of telling their PIN. Their voice itself will be recognized in their app and doing what they want. This way advertisement, how much is the possible, we have to inquire in bank only. This is the advertisement they have just given. And to stop feeling of loneliness. Loneliness is the worst friend of Alzheimer's disease. They go hand in hand. So what we have to do is, if any music therapy is there, singing group, some women like to go to church because they can loudly sing. Even they forget all the songs, they remember only that some chanting of mantra or this. So singing together also will, a family together can sing. Singing can give them a feeling of relieved of loneliness and foster bonds with others. And COVID-19 is the another issue. It's an additional crisis over a crisis of this Alzheimer's. So what we have to do, additional crisis, anxiety and fear of the person will be increased because caregiver is coming to the persons with the personal protective equipment, or we are encouraging the person to put mask when going to the hospital. This is not used to Alzheimer's. He will think what happens. He will just remove and throw the mask. So crisis situation it is. Depression sometimes, loneliness. This already some normal people are telling they are depressed, they are lonely. Then what about a person with the Alzheimer's? Self-isolation, self-quarantine and self-distancing. We are not at all able to educate these people to do quarantine. If at all it happens, self-quarantine. A lot of studies are there on COVID. Please read this. They are not able to identify the person is suffering from COVID or it's a physiological deterioration. Because we know taste will be less, smell will be affected. So they are not able to identify it's due to their physiological deterioration or it's due to COVID. And there are they are showing some of the important things are there, like smell dysfunction can be used as a biomarker for COVID-19. This is used and the result is stating that quantitative smell quarantine demonstrate that diseased smell function but not always anosmia is a major marker for SARS-CoV-2 infection, suggests possibility that smell tasting may help. These are all studies. We are not using that much evidences nowadays, but we have to explore this idea, like smell dysfunction can be in this patient because patient is not able to tell that they have throat problem or symptoms. Sometimes only fever will be able to identify by the caregiver. Whatever they tell, their objective signs may not be able to express. That's why this test is used. This study is telling that. Please refer later. And quantitative smell testing, this is the result. I told you this can be used. Then another study says that a typical presentation of COVID-19 in older adult with a severe Alzheimer's disease. And another changing trend is you look at any home with Alzheimer's disease, old is caring the old. Children are abroad or grandchildren are abroad, grandchildren are working, grandchildren are active. Only parents are caring their parents. In their period of taking rest and sleep, they are caring. So they are also prone for sleep deprivation. Caring, old is caring the old is a trend happening everywhere. So our elderly have to be supported by our institutions, at least if children are not with them. And resources for dementia care in Kerala, you may ask me this to avoid your question. I have just placed this. There are a lot of information. Please search in the site. And I have already told the information specific for dementia care. This page, if you search resources in Kerala, it shows that Alzheimer's disease facilities in Kerala. I'm giving you only government facilities. So you will be well aware what happens in your cities. Like this is helpline for senior citizens, help page, helpline. There are contact numbers. If at all anybody wants, you can write down this. I will be sharing the slide with Vinitha madam. Later you can take the slides and you can see there are helplines in Kunnamkulam district. Every cities in Kerala has addressed by our government and they are assigning people to take care of patients in certain area, but people are not aware and reaching the facility. That's the issue. So make them aware. Itself is a webinar to make public aware of whatever is available. Even any situation like whatever is available for women, children, Alzheimer's, all type of diseases, another webinar topic. So I just touch and go. And Smriti Padam, Kerala State Initiative on Dementia Daycare, Thrissur District, and Dementia Respite Care, Harmony Home, Thrissur District. All this in Thrissur District I gave. Kozhikode ARDSI Calicut, like chapter at Malamar Harmony Home Respite Care. I already gave you the site. Ame, so you have to go to the site and check. And what is our country doing? Dementia caregiver resources across India is ARDI SI. Sorry, ARDSA, Alzheimer's and Related Disorders Society of India, chapters in various cities of India, Dignity Foundation, Helpage India, Portal for Old Age Solutions, Dementia Care and Respite, Dementia Helpline. Sometimes, most of the time, state goes with the central hand in hand, and center help state. And state have its own fund and work separately. Some they are doing with the center. So all the cities, I know that many people are hearing me from all over India. So you can go to this site, Dementia Caregiver Resources across India. All these are given in the site. Even for the caregiver, resources like a dementia care note, this link can be clicked for the caregiver notes are there in Malayalam, it's available. Local languages of particular area, it's available. If at all you want help, contact the numbers which I already gave you. This is the reference, a lot of reference I have done, but I'm not able to place everything for a what beauty of the slides I gave this, that's all. Thank you so much. I wish all of you a Alzheimer's free elderly period. Thank you. Hope I have touched over the area. I'm sorry for the time constraints. So if at all any questions are there, Vinitha madam, shall I stop?
Two questions for you. One is from Hemalata. I would like to know, as a healthcare professional, how to explain the adaptability and emotional support.
For the person. Adaptability in the sense, we know if we have any issue, we will be able to recover after some time. Am I right? If I have some stress, I have failed in particular exam, or I have identified with the COVID-19, I am sure that tomorrow there is a hope. But in this case, I told adaptability, whatever is possible, adjust to that is a big challenge. The person have to adjust with this. So caregiver has to play a role. It's based on the competency of the caregiver, how to make a stress-free environment for the patient and helping the person to adapt. So caregiver's competency is the ultimate thing for this. What was the another question? Adaptability and
emotional support.
Emotional support. Most of the time they are distressed. Patients are distressed. How, you know, they will be wondering. We will be restricting them. Already I have spoke. And they will be expressing some frustration or their sensory perception altered, like somebody was standing in my room when I am sleeping. All this. So caregiver may be telling, who the hell are you to ask like this? Why you are telling all this? They will shout to them. Caregiver have no outlet for their frustration and stress. Only this neutral object will be listening. So what will happen? Vice versa, this will be going back to the patient and it will in turn increase patient's anxiety. So caregiver have to see, express the emotions, like how they are expressing their emotions to the person. Though we are angry, we should be able to control. They have to learn to swallow their anger or anger management in better way. When you are angry, don't go to your patient. If at all you are not going, it's okay. When you are angry, just leave the area. Just watch the patient from far. He is not in the danger. Don't have to speak and give answer for everything patient asks. Just nod their head. Just pat on their shoulder. Just smile at them. They, whatever answer you tell, they don't remember. Am I right? Patient asks you how many days are there in a week. You are telling 7. They don't remember. They will tell again. They will ask again. So why you are giving answer for everything? They will tell 7 days are there. You just want to say, enjoy the caregiving. That's all.
And a few more questions were there. I think you have already covered all those. I'll just raise the questions. What are the common problems faced by the caregivers of Alzheimer's patients and how the caregivers' issues are addressed?
Already I have told their issues.
Yes,
Sorry,
yes.
how to address is I told we can help them by assistive devices. I have already told. Their half work will be over if you are placing calendar in the room. I told, I have already explained. I think due to some net disconnection, most of them have not heard.
Yes. And one more interesting question. How to make them for referral and follow up in this lockdown period?
It's very challenging. But our government has placed e-Sanjeevani. You log into e-Sanjeevani clinic. There are many doctors from various specialties. They will give you response based on your questions. That YouTube videos are available how to use e-Sanjeevani. Governments, there are doctors, they will give prescription Online prescriptions are given for your patient. You can show your patient in video. You can connect to the doctor. Even you, if some doctor you are connected. For example, if they are showing Roy sir, they can connect to sir's assistant through video. Show the patient symptoms if they are not able to explain. Like creases are there on the back or patient particular eye movement, all this. Then doctor will be able to see the patient. Only thing not able to touch the patient. They can just tell, palpate and see all this type. Instruction can be given. Caregiver can be a helper for this. I don't think there is a problem because we have learned in the beginning, if it was a question, it will be stress. Now we have learned, just see, I am sitting very close to Sister Deepa. Even I can, I feel you're just a screen away.
Yes.
So this facility is available. So why don't we use for our patient?
Okay.
Questions?
Thank you, ma'am. And then one more question to Dr. Betty, whether she is available.
Yes, ma'am will be there. Shall I mute then if I don't have to speak?
Yes. Okay. Now, one more thing.
To me?
Okay. To Dr. Betty, we have one more question. Can I ask? Dr. Betty? Or else I'll go to the wind up session. That was an amazing session. Dr. Reena, thank you very much, ma'am, for sharing your great knowledge with us. And you have explained all the aspects which are required for our practical aspects which are necessary to take care of patients with the Alzheimer's disease.
Once again, I thank you, Team Pushpagiri. Our Alzheimer's days are coming only 21st. Before that, you have become the trendsetters today. Thank you a lot. Anyway, whoever is going to observe this day will be benefited out of your arrangements, I think. I thank Sister Therese, my dearest senior, and I do remember her skits and dramas played by her. Whenever I see her face, that come to my mind. And Sister Serena, I have seen from Father Mullais, I think.
And I was your junior too.
Very proud to stand one among you as a Mullarian. Thank you so much.
Thank you very much, ma'am. And now, every beginning has to have an end. And now we have come to the end of this webinar. It's a time to express our sincere gratitude to all of you. Organizing a webinar within 1 week was not an easy task for both of us. We have taken every steps together to make this webinar a reality. First and foremost, we bow our heads before God Almighty for His abundant blessings upon us. I take this opportunity to thank Dr. Santosh M. Matthews for inaugurating the session. I would like to thank our principal, Sister Therese SIC, for her constant support throughout this webinar. Words are not enough to thank our speakers, Dr. Roy Abraham Kallivailil, Dr. Betty P. Kunyumon, and Dr. Reena George, for spending your valuable time with us in spite of your busy schedule. Thank you very much. Respected Dr. Roy, Dr. Reena, and Dr. Betty for sharing your knowledge and experience with us and for the wonderful lectures. A big thanks to all our delegates from all over India and abroad for your active participation. Special word of thanks to our teaching and non-teaching faculty, especially to Sister Serena, who helped us, and our dear students for your timely help and support and encouragements. Mrs. Vinitha Jacob, HOD, Mental Health Nursing, has been the driving force behind this whole process. I thank her for the efforts she has put into developing this webinar. Let me acknowledge the rock of support from IT department to Mr. Marvin and Thomas from MacFast College and our little Joshua, son of Vinitha ma'am, for the perfect technical support throughout this webinar. Finally, knowledge updation shows our obligation to our patients, and of course, it helps us to improve our confidence level and to become excellent health professionals. This webinar would surely be useful in our personal lives too, as we take care of our elders who face challenges due to this disease. Once again, heartfelt thanks to each and everyone. You can leave the site now.